Hello, my name is Gemma and I am a webinar moderator for Physics World. I'd like to welcome you to today's webinar, End-to-End Test for Spine Stereotactic Radiosurgery on MR-Linac using RTsafe Spine Phantom. Before we get started, I would like to go over a few items so you know how to participate in today's event. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You can submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You can also download the customized Phantom service handout from the webinar panel. Today's webinar will be presented by Eun-Young Han from the University of Texas MD Anderson Cancer Center. She will later be joined by Jin-Song Yang, also from the University of Texas MD Anderson Cancer Center, for a Q&A session. This webinar will share the results of end-to-end dose measurements for spine stereotactic radiosurgery quality assurance test in both MR-Linac and a conventional Linac. Eun-Young and Jin-Song welcome your questions, so please do send in questions at any time during the webinar. Eun-Young and Jin-Song will answer as many as possible during the Q&A session at the end of the presentation. Any unanswered questions will be answered by email once the webinar is over. Now I'll hand over to Eun-Young.
Welcome to webinar. Hello everyone. Today I'm going to present about end-to-end test for spine stereotactic radiosurgery on MR-Linac using RTsafe Spine Phantom. First, I'm going to briefly talk about the Spine SBRT in MD Anderson and potential benefit of Elekta MR-Linac for Spine SBRT. Then I will talk about end-to-end test using Spine Phantom, method, results, and conclusion. Approximately 40% of cancer patients present with spine metastasis, resulting in severe pain, fracture, and spinal cord compression if left untreated. Spine SBRT is a viral treatment option for malignant spinal tumors, and it is feasible through the robust programs including simulation for patient immobilization, planning, and image-guided radiation delivery. This is an effective and safe treatment which shows 1-year local control, about 90% even in radio-resistant tumors, with a high and fast pain control. Also, comparing to the conventional approach, Spine SBRT show lower treatment rate as 7.7%. It minimally interrupts the patient's chemotherapy schedule, and this treatment is convenient for patients by reducing clinic visit compared to conventional treatment. Currently, at MD Anderson, we are treating about 200 patients per year. However, there are some challenges for spine SBRT in general. It does come with the risk of potential toxicity. On the acute side, 20% of population experienced pain flares within 5 days. For late toxicity, there could be vertebral body fracture, pinching nerve root, or a spinal cord injury, and esophagitis. Let me introduce the conventional Linac-based treatment. First, we couple SBRT procedure with the following prescription used at MD Anderson. For unirradiated radio-resistant tumor, 24 grade to GTV, 16 grade to CTV are given in single fraction. For unirradiated radiosensitive tumor, 18 grade to GTV, 16 grade to CTV in single fraction. We treat patient with a multi-fractionated treatment when patient has a prior radiation treatment. In those cases, we use a 27 grade to GTV and 24 or 21 grade to CTV in 3 fractions, and sometimes we use a 5 fraction 30 grade to GTV for Burkitt disease. Once we have a prescription, we get into our planning. For planning, as shown in the top picture, the plan is generated by 9 coplanar posterior step and shoot IMRT beams, or as shown in the bottom picture, the VMAT with posterior quadrant arcs. Our planning goals are more than 95% of GTB receiving prescription dose and more than 80% of CTB receiving prescription dose. But many times it cannot be achievable due to hard dose constraints such as spinal cord or esophagus. Instead, we try to make GTB receiving at least 15 gray for local control and keep the unirradiated cord dose max less than 12 gray. And cord is delineated using T2 MRI axial scan, or we use a CT myelogram in post-surgical setting. Here we have one of the examples of thoracic spine SBRT planned in Pinnacle treatment planning. Dark red colored volume shows GTV covered by 24 gray isodose line, and yellow colored volume shows CTV covered by 16 gray isodose line. Bright red colored volume shows spinal cord, the green shows esophagus, and blue shows trachea. As you can see, the plan requires high conformity on targets and rapid dose follow-up from target to spinal cord. Therefore, the plan requires at least 1.5 to 2 gray per millimeter dose drop-off near the cord, and to ensure that rapid dose follow-up outside the target, accurate targeting is required in every step of patient immobilization, planning, and radiation delivery. Let's talk about Spine SBRT treatment workflow using TrueBeam linear accelerator. Initially, we set up the patient with the marked ISO in patient skin marker or tattoo from simulation. Next, the pre-treatment setup is done by ExactTrack with a tolerance of 0.7 mm and 0.8 degree. This is verified by cone-beam CT to see if there is an agreement with the ExactTrack. And then take the MV-KV orthogonal image pairs to check and count the correct vertebrae. Finally, the treatment begins with the final ExactTrack to verify if a patient has not moved. Now, let's switch gear to Spine SBRT on Elekta MR-Linac, since that is the motivation of this study. So what is the potential benefit of Spine SBRT on MR-Linac? Daily MR guidance with MR-Linac can provide improved soft tissue contrast for treatment delivery. The cord dose tolerance was initially set by using surrogate as a spinal canal with intrafractional motion guidance directly on the cord during treatment. Cord dose constraint may be increased. Potential dose escalation for cord tolerance may offer treatment for patients with epidural disease that were previously not candidate for SBRT. In 2018, clinical version of MR-Linac was installed and we treated first patient in 2019. We became the first site in North America to treat a patient with a high field MR-Linac system. Since then, we have treated many different types of disease. Type of patient treated in MR-Linac include pelvic bone mat, GYN, prostate, abdomen, rectal cancer, pancreatic cancer, lymph node, head and neck cancer, and so on. So, How does our treatment workflow differ using MR-Linac? For simulation, patient will have a CT MR sim with MR-Linac couch top on the same day. For planning, plan is generated by Monaco TPS using step and shoot IMRT, and pre-treatment QA is done with RTsafe. On treatment day, daily MR scan is registered to the reference plan image, and adaptive plan is generated by either adapting to today's target position or today's target shape. And plan is delivered after plan review and MU verification by Radical. There is 2D orthogonal cine image available on target. After treatment, post-treatment QA is done with RTsafe, and offline adaptive plan can be generated using today's MR. Now, there are two daily plan adaptation workflow. In adaptive position workflow, the beams in the reference plan are adjusted to match today's position of target based on rigid registration. The plan is optimized on the planning city, and the reference plan becomes a goal of the adaptive plan. In adaptive shape workflow, a new plan is created to match the anatomy of the day by deformable image registration or by manual contouring. Optimization goal is an original IMRT constraint, and the plan is optimized based on the daily MR. So the question is, would Spine SBRT on MR-Linac provide comparable or even better treatment delivery or treatment outcome than TrueBeam Linac based treatment? We see the potential benefit in this new treatment modality and its workflow. We have many ongoing research projects to investigate this area. What are the degree of inter and intrafractional cord motion on MR-Linac with SBRT immobilization setup? How accurate the deformed contour generated on daily MR image? Is there dosimetric impact on variation of daily MR image quality? Can the core dose and target coverage in daily adaptive plan be acceptable comparing to reference plan? Setup and intrafractional motion management are comparable to TrueBeam. Today, we will focus on this last topic: how to perform end-to-end tests for Spine SBRT with anthropomorphic spine phantom on MR-Linac. For the purpose of this study was to assess Spine SBRT treatment plan quality and delivery between conventional Linac and MR-Linac using an anthropomorphic spine phantom. For this study, we needed a phantom for the entire treatment chain, including planning CT and MR imaging, pre-treatment setup, MR-based image guidance, treatment delivery, and dose measurement. So how did the research collaboration with the RTsafe begin? I met RTsafe staff during AAPM 2018, and later we submitted the research proposal to them in 2019. The proposal was accepted, and they let us borrow their phantom, which is unique at the time because it was MR comparable and MR visible. With the phantom, we were able to finish the study and publication. The phantom represents a 10-year-old female. Why pediatric phantom? Because at that time it was difficult to make the adult size with a 3D printer. The phantom was 3D printed and based on CT data of a real patient and has realistic bone and soft tissue contrast shown in CT and MR. The size of phantom is 20 cm wide, 13 cm tall, 11 cm long. It accommodates two ionization chambers into spinal canal and central spine vertebrae. You can find detail of phantom production and Hans field unit and physical density in this paper. The phantom was especially designed for end-to-end test for Spine SBRT. It allowed direct dose measurement in cord and GTV, therefore it can validate clinical treatment plan. This key feature worked very well for our study. In this study, both lumbar and thoracic spine were considered, and I'll explain lumbar spine first and later explain thoracic spine. For lumbar spine, the phantom was completely filled with water before CT scan. The picture left shows how contours were generated. This picture shows sagittal and axial view of CT image and contoured structures of the spine phantom. The two sensitive volumes of chambers were outlined on the CT images after additional CTs with both chambers inserted. GTV was drawn in the central vertebrae where the sensitive volume of chamber was located. CTV was drawn in the body of central vertebrae, right pedicle, and right transverse process following International Spine Radiosurgery Consortium consensus guidelines. The inner wall of the chamber insert in the spinal canal was considered to be spinal cord. Before I move on to thoracic spine, let me talk about electron return effect to explain the rationale behind including thoracic spine. Electron return effect is a physical phenomenon unique to the MR-Linac. As shown in the picture on the top left, under the influence of the 1.5 Tesla magnetic field, the secondary electron in air or low density medium can be deflected by Lorentz force and cause increased dose to neighboring tissue, comparing to zero magnetic field as shown in top right picture. For thoracic spine SBRT, the ERE might occur in the interface between the lung and spine vertebrae for the posterior beam as shown in bottom picture. That is why we decided to investigate both lumbar and thoracic spine SBRT. We did two CT scans, one with a completely water-filled phantom simulating lumbar spine, the other with the phantom partially filled to mimic the thoracic spine. The water level up to anterior border of the body of vertebrae was selected so that chamber in the GTV was completely submerged in water. Therefore, the treatment plan was generated for both lumbar and thoracic spine. Ray station plans were compared with the Monaco plans using plan quality index such as target coverage, pedic conformity index, the gradient index, homogeneity index, R50, V10 grade and Dmax to the spinal cord, and total magnitude unit. Previously, we mentioned prescription for a patient. What you see here is the prescription and dose constraint utilized in the phantom. All plans were normalized so that at least 95% of CTB were covered by prescription dose. This slide shows planning result. This table in the right shows results from 4 plans: MR-Linac and raise station, and a lumbar and thoracic spine. The purpose of this comparison was not apple-to-apple comparison between two treatment planning systems, and instead generating acceptable plan for treatment according to the planning goal. As you can see, all 4 plans met the planning goal. The plan quality indicator, including target coverage, conformity index, gradient index, homogeneity index, also comparable. The beam on time for TrueBeam were 8 minutes, comparing to 13 minutes for MR-Linac. This is due to increased monitor unit with the Monaco plans. Here we have the images to compare 2 plans. The Monaco plan in the top left to raise station plans in the bottom left. The Monaco plan is calculated by Monte Carlo calculation, and the raise station plan was calculated by collapsed cone convolution. We found some interesting points. In the Monaco plan, you can see the sharp dorsal follow-up anteriorly and lodus verge out to the supinferiorly. In the raise station plan, you can see lodus verge out to the anteriorly and sharp dorsal follow-up sup and inferiorly. The figure lower right shows the dose difference calculated as Monaco plan minus raise station plan. The hotter area, less than 25 centigrade, in the anterior border of the target border shows ERE in Monaco plan. The top right picture shows cumulative DVH, and Monaco plan shows as a solid line, and the raise station plan shows as a dotted line. Here we have the TrueBeam Pretreatment setup by BrainLab ExactTrack on the left picture, and verification by variant onboard cone-beam CT on the right. The position of phantom was corrected within the tolerance of 0.7 and 0.8 degree with variant IGRT couch controlled by ExactTrack. The total imaging takes about 2 to 3 minutes. On the setup of MR-Linac delivery, MRI scan was performed in 2 minutes. T2 weighted MR image was then automatically imported into online Monaco TPS. The picture in the right shows image registration of planning CT versus daily T2 MR images. Once the T2 image was registered with the planning CT, the isocenter shift was determined and adaptive plan was generated and compared with the reference plan. The adapted plan was then exported to MR-Linac treatment console for delivery. As previously mentioned, all MR-Linac plans must go through daily plan adaptation. We can see the plan comparison between the reference plan in the top left, in the daily adaptive plan in the bottom left picture, including isodose line and sagittal view. We can see the 2 plans are close. And on the top right, the cumulative DVH between reference plan in solid line and the daily adaptive plan in dotted line. The dark red on the left is a cord chamber, and green is a spinal cord. Red on the right is a CTV, purple is GTV, and a blue color shows GTV chamber. As you can see, the target coverage matches with the reference plan very well, but cord dose and cord chamber dose, which is located in low dose area, increased. Let's see this a little bit more closer. This table shows the dose difference between lumbar spine reference plan versus 3 daily adaptive plans. These adaptive plans were calculated with different optimization options, such as optimized weight, optimized shape, or original segment under ATP workflow. All the plan quality index are consistent within 3% except the spinal cord maximum dose, increased by 10% comparing to the reference plan. Result on the thoracic spine, all the plan quality are consistent within 2% except the spinal cord maximum increased by 9% comparing to reference plan. Why is it? This is because of the way Monaco optimization treats organ at risk such as the spinal cord during the adaptive position workflow. About this issue, one of the authors explained like this. Author Russian et al. Said, optimization algorithm in ATP workflow has been made genetic for all sites, and it favors target coverage while maintaining the overall OAR dose. There is no explicit method for user to specify OAR is serial or parallel. Let's move to the next step in process. Plan delivery for chamber measurement. The extrading A1SL MR chamber was used as shown in the left. This chamber was designed for absolute dosimetry calibration under magnetic field. The collector of the chamber, approximately 1/3 the size of A12 Farmer chamber, allowing for finer resolution measurement. The raise station plans were delivered in TrueBeam SDX with a 6 MV FFF beam with a 120 high definition MLC. The Monaco plan were delivered Electa Unity MR-Linac with a 7 MV FFF beam with 80 MLC. The core planar step and shoot IMRT beams were employed with 9 posterior angles, and beam angle were modified to avoid high density material at the edge of MR-Linac couch. On Monaco, Monte Carlo dose calculation were performed with statistic uncertainty less than 1% per calculation. For plan adaptation, adaptive position workflow was only used. Here we have 2 images of a chamber measurement setup for TrueBeam with the exact track array on the left and MR-Linac with the body RF coil on the right. In the picture right, the MR-Linac isocenter is fixed at the center of the board at 143.5 cm, which is 13 cm above the couch top. Therefore, a 7.5 polystyrene foam block was used under the phantom in order to raise the target in the phantom to isocenter level. The table shows the detailed chamber measurement between raise station and Monaco lumbar and thoracic spine plan. The top portion shows the results from raise station. The bottom portion shows the results from Monaco. First 2 columns shows the chamber windows from lumbar spine, and next 2 columns shows the chamber windows from thoracic spine plan and measurement. This is percent difference between measurement and plan, and percent difference was calculated by measurement minus reference divided by reference. The result has been updated as follows. In the initial measurement, the dose difference was higher in the spinal cord in the thoracic spine plan as 6.9% for raise station and 3.9% for Monaco plan. But after we realized the core dose wasn't pushed hard enough because it already met the core dose constraints, we generated new plans with lowered core dose as much as possible. and it helped reducing the dose difference between measurement and plan. Therefore, we can say, regardless of the machine or lumbar and thoracic spine plan, the planned dose for the chamber in GTV and spinal cord can be measured within 3%. For the discussion point, SBRT treatment plan and delivery in lumbar and thoracic spines were assessed in TrueBeam and MR-Linac using anthropomorphic spine phantom. In the MR-Linac plan, the mean dose of core chamber volume in the adapted plan increased more than 8% comparing to the reference plans. This could be a limiting factor of using ATP plan adaptation workflow for the Spine SBRT plan. More research needs to be done on issues related to thoracic spine planning and delivery due to ELE and ATS workflows. In conclusion, Monaco treatment planning system for Electa MR-Linac can generate the plan comparing to the RayStation treatment planning system, and Monaco planned doses for the chamber in the GTV and the spinal cord were both measured within plus minus 3% comparing to the plans. This study found the Spine SBRT treatment planning and delivery for MR-Linac is feasible. However, more comprehensive effort including optimizing adaptive plan is needed. It is valuable to use an anthropomorphic spine phantom for end-to-end tests for Spine SBRT. I thanks to all co-authors for this paper. Also, I want to thanks to all MD Anderson radiation oncology and radiation physics staff and RTsafe staffs and leaderships. Thank you for your attention. I can entertain if you have any question.
Thank you, Young, for a great presentation. We now have a quick poll. Our poll question is, if you could customize the spine phantom presented here by adding an extra feature, what would you choose? Your options are high density markers, metallic spheres for co-registration, thermal imaging capability for SGRT implementation, prosthetic implants, other dosimetric options, film, gel, OSLDs, etc., or all of the above. I will read that again. Our poll is, if you could customize the spine phantom presented here by adding an extra feature, what would you choose? Your options are high density markers, metallic spheres for co-registration, thermal imaging capability for SGRT implementation, prosthetic implants, other dosimetric options, film, gel, OSLDs, etc., or all of the above. Thank you for your responses. We'll now take a look at some of the questions that have been sent in. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Our first question is, how do you choose between IMRT versus VMAT planning for TrueBeam treatment delivery?
Okay, I can answer the question. You can hear me, okay? Can you hear me, okay? Yeah,
yes, we can.
Okay, so when we start the Spine SBRT program, we use IMRT for all sites. And then as time goes on and we build our experience and then we move on, slowly move on to VMAT planning. So so currently we use from C-Spine
to T4, we use IMRT, and then below T4, and then to the sacrum, we use a Pretreatment plan. For both of the step-and-shoot IMRT and Pretreatment, we use posterior beam or arc.
Lovely, thank you. Our next question is, why are MUs in Monaco plan higher than race station plan?
So I think, so if I remind attendees that both of the plan was done with the IMRT, exact same angle. So main issue with the MU increase, I think, is related to SSD difference.
Thank you very much. Our next question is, what was the issue with thoracic spine planning and delivery?
Yeah, that's a kind of a most interesting finding in this study, that for the thoracic spine, that we will see the ERLI effect during the planning. So, for example, that we will see harder spot in the anterior border during the planning. So when I consult with the Monaco expert, that we will be able to kind of remove those hot spots, but I haven't tried yet. So we should have special attention to those hot spots in case esophagus was abutting. And also, not only that, we will see the spinal cord, those increase more than lumbar spine in the thoracic spine. So that's why we need a little bit more in-depth investigation before we move on to clinical implication for the thoracic spine.
Thank you very much. I think we have been joined by Jinsung Yang as well. So our next question is, will geometric distortion from MRI affect the SRS plan during online planning?
So yes, to answer this question, so we have done some study on the geometric distortion. In general, the geometric distortion of the MRI is very small on the electric unity MR-Linac. So some rule of thumb is that within the 10 cm of the imaging lateral center is less than 1 millimeter, and within 20 cm is less than 2 millimeter. So if we can set up the patient, the spine is close to the imaging center, the impact should be very small and mostly negligible. But we'd like to bring your attention is that because the spine SRS required the very small margin. So when we do the plan, should pay attention to the geometric distortion. But I don't think this will impact the plan at all.
Okay, thank you. Our next question is, compared with CT guidance using a regular Linac, what is the major benefit of treating SRS with an MR-Linac?
Yes, it's the major benefit of using the MR guidance versus CT guidance for the spinal surgeons, that you're able to see clearly of the spine, and especially I think this is very useful to the interpretation variation, because we're able to use the online planning to account for this variation. So potentially you can better spare the spinal cord dose.
Thank you. We've had another question come in. Can you explain the difference between adapt to position and adapt to shape of the online plan adaptation?
So let's talk about online plan adaptation. For adaptive shape, So let's talk about adaptive position first. The adaptive position is sort of similar to the traditional IGRT. So the plan adaptation is based on the position difference, it's still based on the original CT. That will not take into account the anatomy difference on the treatment day from the simulation day. Adaptive shade is the actual plan adaptation that will take into account the anatomical difference. So to better spell the spinal cord dose, it would be best to go with the adaptive shape and the actual plan adaptation.
Thank you very much. Our next question is about detector inserts. Can the detector insert be placed in a specific location within the spine phantom, or are they fixed?
I believe it's customizable. So first of all, location-wise, that inside the phantom, wherever you can you want, I think they can locate the chamber, and also specific chamber design, and then they can conform to exact chamber you are going to use. That's what I think.
Lovely, thank you. Our next question is, how many IC inserts can be incorporated in a spine phantom?
I think it can be flexible, but so far I have seen two chamber insert, and it can be measured at the same time.
Great, thank you. We've had another question come in. Can you reduce planning margins with MRL?
I can answer this question. So, with the spinal surgery, the margin is already small. So think about that during the treatment, the intraflexion motion should be very small for the spinal cord. So if with the online adaptive planning, so I think we're still able to reduce the margin if needed, but we need to be very cautious doing that.
Thank you very much. Our next question is, can the phantom accommodate any type of point detector?
Point detector, yes, I believe they can make for the OSLD and the ion chamber and the film, and then a gel. I have used gel with other type of the phantom from RTsafe.
Thank you. We've had another question. Can the spine phantom accommodate any film or gel insert?
I believe so. Yeah, I haven't used it, but I think it's possible.
Great, thank you. I can give 1 or 2 minutes to see if any more questions come in. People are still asking questions. Okay, we've had a question come in. Comparing doses using Monte Carlo calculation, do you use dose to medium, dose to water, or do you apply an override of the density of the CTV or GTV?
I think that we used the dose to medium. We did not override any density for CTV and GTV.
Great, thank you. Again, I can offer 1 or 2 minutes while people are sending in questions.
Mm-hmm. Yeah, one thing I wanna say that there is as the previous slide shows, that a lot of research kind of need to be done. So anyone have more question or interested in research collaboration, please email me.
Okay. We have had another question come in. Given choice, which machine will you prefer for Spine SBRT and why?
As I said, we are not clinically implementing the Spine SBRT on MR at all. I think there's much more research need to be done, including intrafractional motion management. So, I mean, currently, if I have to choose, we have to go with the TrueBeam 3 until we make sure the treatment is comparable to the TrueBeam Linac-based treatment.
Yeah, I'll say that it's mostly. I'm thinking that mostly it's because based on the machine itself with the MRC, especially for HD MRC, if it's available, possibly the MR guidance would be better. If with the HD MRC plus the MR guidance.
Thank you very much. We've had some more questions come in. Did you compare the dose calculated with Accurus and MC?
Compare the dose calculated with Accurus and MC. No, I have not.
Okay, we've got another question. What is the treatment time comparison between the two modalities?
Okay, so treatment time, the nominal dose rate for the Linac was 600 mU per minute, and then MR-Linac was the 425 mU per minute. So that caused kind of a longer treatment, not only the increased MU.
Thank you very much. We do have 1 or 2 minutes left if any more questions are coming in. Okay, I think that brings today's webinar to a close. If your question hasn't been answered, you will receive a reply by email. If you would like to watch this webinar again or recommend it to a colleague, it will be available shortly on physicsworld.com. Just click on the audio and video tab and go to webinars. On behalf of RTsafe and our presenters, thank you for joining us today. This webinar is now over.